Good afternoon. Assalamualaikum to everyone. For those who joined for my sharing session today, I was grateful to have the opportunity recently to go to Vienna for my 2 weeks of electives, which is part of the master program. We have a 2 weeks elective during our third year. So without further ado, I'll start with the overview of my my lecture today, sharing. Okay, the overview, I will share about my learning objectives, the preparations that I had, and briefly about Medical University of Vienna, and about the Department of Emergency Medicine and miscellaneous bit. So the overview, yes, this, as I mentioned, this was an elective program. We are free to do what we are planning to do, but I consulted Prof. Khaldun that I plan to do it in Europe, and he suggested a few countries. So one of it is Vienna. Then Vienna is a state, actually. It's in Austria. So I had that recently from 30th of June till 11th of July. I specifically attached at the Department of the Emergency Medicine at Allgemeines Krankenhaus, AKH. That's how they pronounce in German, but forgive me if my German is not that, correct. Allgemeines Krankenhaus is the General Hospital of Vienna, which is affiliated with the Medical University of Vienna. So that's the building. And the learning objectives, I specify about the ECPR because the Department of the Emergency Medicine is a center for the Vienna ECPR, is a center for Vienna ECPR. So one of it is to understand the clinical indications and patient selection criteria for ECPR, to observe the team coordination during ECPR, because I never exposed to ECPR before and we don't have that in our country yet. And the third is I would like to gain insight about their ED practices in AKH, in Vienna, to build a working network with the international communities, especially in Vienna and Europe. And also the last but not least is to enhance my personal and professional experience in the international setting. So before I proceed, I had a few of administrative preparation that I had to do. And if possible, it should apply to the university 6 months earlier as an observer. So for this recent observership, I contacted first Prof. Khaldun, and then he gave me a contact person from the Medical University of Vienna. So that was Dr. Florina Regale and also Prof. Heinz. And they gave me a contact of a supervisor from the Department of the Emergency Medicine. And I was so delighted to get Dr. Ingrid Magnet as my supervisor because she is the director of the ECPR Center. And then I also have to email to the department through their secretary and also to the international office. At the same time, we have to inform the ED faculty. Cik Nabila will write a formal letter to the university, and then we will email the university by ourselves, inform our supervisor. My supervisor is Prof. Dr. Ismail, and also the HR, because I'm a service I'm a service MO in UKM, so I only have to inform the unit latihan of the UKM. And then I submitted the required documents, and finally, to obtain the approval for the university, then we will proceed, and also the acceptance letter. So again, these are the documents that I have to settle. First is that letter from the department, the HOD has to sign, and then the university will send the observer application form and a letter of intent for observership, fill up the forms, and then submit to the secretary of the emergency department. And then they will reply back through the international office that I need to do all the certificate of vaccination and immunity. Like when I received that form, I was like, wow, like I have to do some vaccination on myself too. Which meningococcal, I have to take DTaP as well. And then I need to do some blood tests on the MMR, hepatitis B and such. And then I have to make sure those are certified and clarified and then get a health certificate and then submit it back to them. And they also requested me to take an insurance policy, and they have specified the figures, and it has to be in euro, quoted in euro. So I use this CareMed insurance policy from German. And last but not least, send a letter to the HR. So all in all, this process take about 2 months plus. Yeah. So after all that settled, then after the confirmation, Then I proceed with purchasing the flight ticket and accommodation. SIM card, I bought a SIM card over there, and then I have to be familiarized with the local transportation. In Vienna, they use a lot of trams and the trains, and they use this app Vienna Mobile. So you have to purchase the tickets online, and it's very convenient. I brought some food as well for halal purposes, and then I managed to learn a bit of German language. At least they call hallo, and then that's for hello. Uh, then this is my phrase that I have to say every day. Ich bin Nurhuda, ich komme aus Malaysia. So they'll understand my name is Nurhuda, I'm from Malaysia. So that's my go-to phrases that I speak every day to them. So besides that, bring the elective logbook and the assessment forms to be filled up by the supervisor. And of course, last but not least, cash. That's the most important, cash. Spend a lot of money there. Okay, then I'll proceed with about Medical University of Vienna, the overview. So Medical University of Vienna is one of the oldest and largest medical universities in Europe. So it was a great opportunity for me to go there. And it's affiliated with the AKH, which is the Vienna General Hospital, which is one of the largest hospitals in Europe. And this hospital is top 25 in the latest ranking of world's 250 best hospitals. And it's a great hospital, a great opportunity to learn, because this integration of the university and also the hospital provide a great platform for us to learn. Especially it has a high equity departments like ED, the emergency medicine, critical care with the ECPR center. And about the Department of the Emergency Medicine, it comprises of a 7-bed for resuscitation, and or they call it ICU, and also 7-bed for observation ward. The setting are different than our setting, so when I went there, I was quite confused with the system, but after a while, then I get used to it. And this Department of Emergency Medicine, they are recognized as Austria's first certified cardiac arrest center by the German Resuscitation Council, and it also has this Vienna ECPR center. That's what I'm looking for. And they are active in resuscitation, education for students and staff, including first aid, ALS, and simulation training. So first, about the cardiac arrest center. So they work coherently with the other departments, such as the intensive care medicine, the interventional cardiology, neurology, radiology, and they also cooperate closely with the Vienna Ambulance Service, which is responsible for the preclinical emergency medical care patients. So the quality of the treatment have to start early. So start from the pre-hospital care itself. So that's me with the pre-hospital, with the paramedics, and that's a Lucas tree. For all the CPR, they will transport the patient, and patient is on Lucas tree for the chest compression. Yep, this is my beautiful supervisor, Dr. Ingrid Magnet. She is the program director for the Vienna ECPR Center. So ECPR is extracorporeal membrane CPR, which they use ECMO, extracorporeal membrane oxygenation. And this hospital has been doing ECPR since 1992. I was surprised to know that it has been for more than 30 years, and I never seen that one in Malaysia. So it's one of the Europe's most experienced ECPR programs integrated with the AKH's Cardiac Arrest Center. So yeah, and so how they managed to create this program, they have a certain protocol to make sure that it is successful. So it has to be started from the pre-alert and activation. So this service is available 24/7 for the adult patients with the refractory cardiac arrest. Means the refractory, there has to be in cardiac arrest for at least 10 minutes after performing ALS. Okay, so the EMS first will identify, are this patient a suitable candidate for them to alert the ECPR pre-alert. So they will look at these 5 ECPR, the criteria. Either it's a witness arrest, means someone is there witnessing this patient is collapsed, and then the bystander CPR is performed within the first 5 minutes, and it has to be a high quality CPR. The age of that patient should be around 18 to 70. And if the person has started the CPR when they attach the defib, and it should be detected as either shockable rhythm or is a PA with a rate of at least 50 per minute. The AED, if they first attach the AED and they recognize either shockable rhythm or PA, then estimated the hospital arrival is within 40 minutes. So the EMS team will immediately consult with the ED intensivist who will carry a phone. This is not really the phone that they use for the ECPR, but this is the phone that all the doctors there are using. They will inform the ED intensivist within that first 10 minutes. So the ED intensivist in the hospital, in the emergency department, will use this time to find more information about the patient's medical history, whether patient is contraindicated to do ECPR. Should we proceed with the ECPR? This is the time where they make the decision. If they decide to make it, then they will prepare the cannulation and stuff. So after that pre-alert, now is the task for the emergency consultant, the intensivist, to decide, okay, let's proceed with the ECPR. But they have certain criteria for them to follow. So these are the criteria that are strictly followed. Again, the first 5 that we mentioned previously, and then which they need to identify either these due to reversible causes that causing the cardiac arrest, and there is no underlying condition that limit intensive care, or like ESRF patients or patients have liver failure. So certain criteria are contraindicated. And then is the LUCA CPR applied during the transportation. And they're really strict with the time targets. So the ALS, from the ALS to the decision making has to be within 10 minutes. And then from the ambulance to arrive to the ED should be within 14 minutes. From the cardiac arrest to the starting of the ECMO flow should be within 60 minutes. Should the arrival, let's say the patient arrive after 60 minutes to the ED, so they will cancel the ECPR, despite they already prepared for ECPR. I was unfortunate actually, because I aimed to see one successful ECPR, but all the cases that came when they already alerted for the ECPR, finally the patient actually attained ROSC before they even proceed with the ECPR. So yeah, I didn't get to see the cannulation part, but I managed to see the preparation, the team, how from the pre-alert and the preparation part. Yeah, so this is the form that they have prepared by the Vienna ECPR program. And next is the preparation part. I only see it until this part where one person will in charge of the ECMO machine, and then 2 specialists will be in charge for the perfusion and cannulation. And they have the critical nurses will prepare the beds and everything. So as you can see in the photo, that the one here, this is the ECMO machine, and this is like the ECMO cannulation thing, and then this is the mobile ultrasound. And so they have to put the color to it because they have lost 2 of them because during the busy thing, so they because it's small, it's mobile, so they tend to lose it. So I asked them why they make it so colorful. And last but not least, they have TEE for cardiac assessment. So during the setting, this is their resuscitation area for the ECPR. So one person will stand here at the head after the intubation. So one doctor will perform the TEE so that they will limit the interruption, to minimize interruption of the chest compression. So the perfusionist for the cannulation is over the side at the end of the bed. So she will do the cannulation and the ECMO machine is at the side. So at the same time, the ER nurses, the critical care nurses will prepare the medication and so on. So at that time, they will target the temperature of the patient hypothermia at 33 degrees and aim for at least 24 hours. And then, in that form of the ECPR, there's also form for them to fill up the TEE findings so that they can find out what are the reversible causes, either aortic dissection, pericardial tamponade, or persistent asystole. And then they will do the monitoring, they'll prepare the anticoagulant, they will ensure the vasopressors, sedatives, and analgesics are available, do the blood test, And then the ECPR post-initiation plan, they will undergo coronary angiography and a whole body contrast enhanced CT, and then the patient will be transferred to ICU for further care. And I got more information is actually from this paper, which was just published by the Dr. Ingrid Mena and the team recently in May 2025. So after I read that, like how they actually explain how the structure of the ECPR program was successful and how along the years, over the 5 years, they managed to have a good outcome. So these are the poster that they put there in their department. So I snapped the poster so I can read something about it. So what they are looking for is a long-term survival and a favorable neurologic outcome. So which is either patient will attain CPC1 or CPC2. So CPC1 is a patient will get good cerebral performance, and CPC2 means patient has moderate cerebral disability, but patient is still conscious, still sufficient cerebral function, still able to be independent to perform their daily activities. Okay, so that's the outcome they're looking for. So since they're performing this Vienna ECPR program from 2020 to 2023, so it seems that 25% or 1 in 4 patients who survive to 6 months with good neurological function who attain the CPC1 and 2. And they have shown the trend is increasing from 15% in 2020 to 37% in 2023. So this tremendous improvement is pretty much because of the structure of the ECPR program itself. How from the pre-hospital care, they really focus on the strict criteria that of the patient selection. Patient have to start with early high quality CPR from the pre-hospital care, the bystander CPR, the transfer, the timing, and they become more efficient as the time goes on. So that's what they're trying to say. Over the years, they become more efficient. So these are the reasons why they have these better outcomes. Improve program restructuring. There's an increase in the case volume, so they have more experience and become more efficient, and better pre-hospital care and early recognition. They have a shorter low flow intervals, meaning from the time onset of the arrest to the time of starting the ECMO flow has become shorter, means they have become faster in doing things, and the learning curve, which they have become more efficient over time, the team. So it's definitely a teamwork. It's not something easy for them to reach that level, but I really applaud them for their great success. And I was very honored to be there and be exposed to this great team of people. So yeah, that is about the ECPR. So my next learning objective is for me to learn about the structure of the ED, how differ is their ED as compared to us. So first and foremost is their triage system. They are using the SC triaging, which is scored to 1 to 5. And this triaging is based on how many resources are they going to use for that particular patient. So if SC5, no resources at all. SC4 is if only one resource only. For example, just a simple illustration, you just need to do one suturing or something like that. And most of the time when I was there with them, I mostly see the SC1, 2, and 3 in their department. So after they triage the patient, for those who are not fulfilling the emergency cases, who are stable, they can inform the patient to go to the outpatient care, or they call it first aid. This is at level 5 of the hospital. So so patient is not seen in the ED, but is informed to go to the first aid, which is like our clinic kesihatan setting. Okay, and then secondly, thirdly, the difference is that they are separated from the trauma emergency. So any trauma cases is channeled to the traumatology shock home, which is a trauma emergency room. Is the team involved in this trauma emergency are the trauma surgeon, orthopedic surgeon, the NS team, radiology, and ICU. So in that trauma resus area, they have a CT scan and also the X-ray. So patient will just be on the bed, and the X-ray will come to the patient. The CT scan is on top of the patient, and everything is done in just that one room. Yeah. So I didn't see trauma cases while I was there because it's in a different ED. Next is about their multidisciplinary team. So during the office hours, which during 8 a.m. to 3 p.m., okay, patients can be redirected to the respective discipline outpatients clinic in their clinic. Meaning, for example, that day I saw a patient coming in with for vaginal bleeding. Patient had a follow-up under the gynae clinic. So patient come, they will inform, okay, you can go to the gynae clinic in the whatever floor. So each department, they will have their own outpatient clinic in their department. So our team, the ED, will only see the case, the life-threatening cases, for example, like chest pain, shortness of breath, or if a stroke, for that kind of cases only. So after 3 p.m., the patients who come to the ED are no longer redirected to their clinics, but the doctors from those departments will come down to the ED. They will get one room for each team, which so one MO will be in the neurology team, one in gynae room, a neuro room, gynae room, there's dermatology room, ENT, Euro, MFS, Ophthalm. So we don't have to see the cases. The triage person will directly channel the patient into that respective rooms if required. So that's how they don't have congestion in their ED. Their ED is really focusing on the life-threatening cases only. So that's what I like about the hospital management. And most of the time I was in this area, which is called ambulance. When they asked me, oh, are you in the ambulance today? I was like, no, I'm in the ED. I'm not in the ambulance. And actually, I misunderstood. Ambulance means outpatient. So this is their outpatient setting room. They will see cases, can be SC2 or SC3 in this room. So usually cases is similar to like our yellow zone case. For example, patient come with chest pain. So they will bring patient to this room, lie down on that stretcher. They will do the ECG, do the echo, and then the doctor will sit on the table with a chair. They have even like a stool for them to do blood taking. And in this room is also completed with all the medications and also the emergency and also the trolley for blood taking. So it's quite complete. It's just so they have about 3 of these kind of rooms, which they call it ambulance. And after one patient, let's say after done with the ECG and all that, they can just tell the patient to wait outside. Yep. Next is, this is what I see. Besides the structure, they also actively provide training for their doctors. So one of it is they have this ECPR training, which I'm going to be missed, which that will be in this coming September. And actually on my second day there, they had a TEE training, transesophageal ultrasound, for their junior doctors. But I didn't had a chance to attend at the time. And then they were also keen and very enthusiastic about research activities. You can see a lot of posters in their ED that's showing about the current or probably the ongoing researches that they have been doing. So one professor is doing research on this pulmonary embolism, which is in the Spirare 2 PE trial, one in the Princess 2, ultra-fast hypothermia and cardiac arrest. One is doing the targeted temperature management in ECPR, which is Tanner study. And one person is doing the patient with allergic reaction of angioedema. So yeah, you can see fascinating researches that they have been doing. Yeah, so these are new things to me that I see. On the left, this is actually their trolley if they're escorting the patient, let's say to send a patient for a CT scan, the unstable patient. They will bring this entire trolley with the defib machine, cardiac monitor, with all other things, the medication, ambu bag, everything at the below. And this is the one of the senior staff nurse, the ICU nurse, was demonstrating to me about this transvenous pacing, because they said transvenous pacing is also done in the ED by the ED team in the ED. Yep, this they put a cannulation. This is the machine, and this is their latest ultrasound machine, which has a cardiac monitor can be attached to it, so that they can do the echo concurrently with the ECG, the cardiac tracing, so that they can specifically look at what phase of the heart, systole or diastole, to determine the heart rhythm. And this is the pleural vent. I saw them doing this for the case of simple spontaneous pneumothorax in a young guy. These are the medications that they always prepare early, and they keep in the fridge for any case if should they require it, like ketamine, propofol, in the case of if the patient is intubation. So it's already well prepared by the nurses. I followed them for one of the code blue patient collapse at the ground floor. At the lobby. And they also have their own labs. And this is the research lab. So some of the researchers in the department are doing some blood tests. They're requiring certain blood tests. So they keep the data, everything is in this lab. So that's a cool part. They are very, enthusiastic about research. So yeah, my next learning objective is to build networking with them. So this is a picture of me with Dr. Ingrid Mednet. This is the junior doctors. This is also another consultant, Dr. Alexander Newberger. This is the specialist, Dr. Teresa. This is Dr. Kathy, and this is Dr. Georg. They were very nice to me. They're very kind, and they gave me this very priceless souvenir with their names on the T-shirt. So I'm very grateful that I met all these lovely people, and they are very inspiring. So one thing that I learned from this team of ED members here, they are all in internal medicine, because they don't have a specific emergency physician program in the Vienna Medical University of Vienna, sorry. So they are from internal medicine, and then they specialize in the ICU care. So if they want to be doctors in the pre-hospital care, emergency physician, so they can take another course to be specialized in the emergency physician. And at the same time, the training of to become a specialist will take them 6 years, but at the same time, most of them are doing a PhD. So their research will be considered a PhD. So by the time they complete their training, 6 years to become a specialist, they will also hold a PhD. So that's something interesting to know about them. So they all are very positive about it. And one of the medical students already in the final year told me, I asked him, like, why are you here in the department? Oh, I come here to see one of my supervisors to discuss about my topic for my PhD. I was like, you don't even sit for your final exam of your final medical student exam, but you already start thinking about PhD. So that's their mentality over there. They are very enthusiastic about learning and about, being professionals. Yep. So these a few other memories that I took with these other staff nurses at the triage area. They're all very friendly, very helpful in translating German language to me. Yep. Oh yeah, I forgot to mention, they use German in everything, 100% German, in their normal daily conversation, when they're clerking case, even in their forms, their documentations in the computers, everything are in German. So they are being very nice to translate everything else back to me. So these are the ICU nurses. This is Dr. Florina, who has been helping me a lot. And this is Madam Cornelia, one of the secretary in the department. And yep, coffee, they really enjoy coffee so much. And if one of the doctors, his name is Dr. Georg, every time when he's working and he sees me, he will give me a free coffee. So it's so sweet of them. Every morning when you see them, they will carry like 1 mug of coffee. I think, yeah. One of the doctors bake a cake on that day, and they have this coffee machine, Nespresso machine, in their own pantry. Yeah. So they recommended me to try this cake. It's a traditional Viennese cake, a Sachertorte, and I had a nice coffee overlooking the Schönbrunn Palace. Yeah, that's in Vienna. And I had opportunity to go for actually it's a dinner hosted by Dr. Florina and also Prof. Heinz and family for me and my family. I had opportunity to watch a royal orchestra in one of the orchestra place in Vienna. This is the Schönbrunn. So yeah, besides the hospital, so you get to do a lot of sightseeing as well, because I went there during summer. The daytime was longer the night starts at 9 p.m. So after work, like 3, so I still have time to take a train and go to all these places. And then this is a picture of me in front of the house of Prof. Heinz, which he lives outskirt from the Vienna. And finally, they gave me this like a certificate that I have completed my 2 weeks of observership at their department. So yes, that was lovely. And Dankeschön, bis später, Vienna. That's all about my sharing. So I open to the floor. Should anybody wants to ask me anything?
Hey, thank you so much, Dr. Huda. Congratulations for completing your observership in Vienna. You are our second batch of trainees who engage with Vienna University Hospital. And this time is a bit more detailed in terms of the posting, which is concentrating in um, uh, the resuscitation unit. So I would like to say thank you, Dr. Magnet, for entertaining our students when they are there. And I hope this will not be the last. We'll be sending students all over the place. But I think this hopefully will pave the way for our students our trainees to visit you. And perhaps if you are interested for your trainees also to come and visit us in Kuala Lumpur. So, Huda, I have a question. One of the criteria of the resuscitation to go for the process is 70 years old. Is that maximum age for eligibility for going for the criteria? Or,
Yes, correct. It's
so
yeah, that's the
anybody above,
maximum.
that's the maximum age
Yeah.
for the process to go. Okay. So and from 18 years old, as you said, is it only for adults?
Yes, it's only for adults.
Okay. So is this center cater for both adults and children as well, or only adults?
This emergency medicine caters for adult.
Okay. So for kids, there's a separate or
yes, they have separate. So because they are managed by the internal medicine specialists. This department is managed by the internal medicine specialists. They are all subspecialty in ICU, intensive care. So they cater adult patients.
Okay. And it's nice to see that it also couples with ECMO and also hypothermia as part of the resuscitation and try to, I think, cerebral protect the patient. Yes?
I think so, yes, because, yeah.
I think it's the previous slide. That's the criteria you put up there.
Yep, the 33
cool
degrees
down,
Celsius,
yeah,
this one.
33 degrees, yes, yes. Okay. And is that maintained in the same place where the ECPR started, or they moved to ICU setting after putting all the cannulation and?
I think they will start early because they look at their EDs as a ICU. Basically, the setting, the machine, the way how they setting everything, it looks like an ICU. It's different than our ED setting here, our resus setting. Yeah.
Yeah. So this is a very specialized emergency department, as you say, or it's also part of emergency department?
It's in the emergency department. So
Okay.
because they have this cardiac arrest center and also the ECPR center, I think that's why their resuscitation area is very specialized with the machines, the monitoring. Yeah.
Right. Okay. Just very interesting. I just have another question about trauma. Any particular reason you think there are not so many traumas seen in Vienna?
It's not so
We
many.
see trauma every day.
It's not that I don't, because I wasn't attached to that trauma area.
Okay,
Because
okay.
it's separated. This emergency department only is like an internal medicine. Only they are specialized in emergency treatment. And then for trauma cases, we'll go to a trauma room, which is managed by the trauma surgeon, orthopedic surgeon, and yeah, NS. So that's how they segregate it, and then I feel that that's why they can focus more on the treatment in their own ED setting
Right.
during the resuscitation.
Okay, very good. Well, what about patient load that you noticed?
They said
I
that
think
they see a lot of
our
patients,
yeah.
but I know I just kept quiet. But yeah, like our hospital is like packed.
Yes,
Um,
I think that's also one of our limitation as well.
yeah,
We have a high patient load, and that kind of may have take a lot of time and effort. Everybody is stretched thin, and therefore can't really focus. So the setting that you mentioned is very focused
yes.
and
I think
very
because we lump everything into one ED. We lump
exactly.
all cases,
Mhm.
PITS cases, trauma cases,
But
but for them,
now we are trying to separate the peds from adults from
true.
our pediatric hospital just next door. Hopefully, the emergency department have taken the load for pediatric patient, but still the cohort will be like everything, right? So,
Yeah.
so this is a kind of a very focused, specialized approach to deal with patients. And I assume because of that, the requirement for uh, triaging the patient for particular thing is starting much earlier, even pre-hospital care setting
True.
already. Yeah.
Yeah.
One of the things that we see that we try to do is also doing the thrombolysis, right? Thrombolytic therapy for patients start from the pre-hospital care,
Hospital.
but we're still struggling with that, even in big city like Kuala Lumpur. So a lot of things seem to be ironed out first. Yeah, very interesting. Okay.
Well, I'm delighted to inform that Dr. Ingrid Magnet, Dr. Michael, some of the specialists, some of the doctors from the Vienna, they are online as well. Thank you so
Yeah,
much for
yeah.
listening.
Can see Dr. Magnet there. Yeah.
Yeah.
Okay. Any other
You
questions
gave an
from the floor?
exceptional presentation.
Yeah.
I'm really impressed.
Yeah, I hope Huda managed to also share some of her knowledge, input of our system with your staff when she was there. It's part of the requirement that we have for all our trainees that goes out to do observership, to also offer to present something from Malaysia for your staff and for your own setting. I hope that was done.
Absolutely.
Yeah. Yes.
Oh, Dr. Ingrid, hello. So beautiful. Okay.
Okay. So, any other questions that we can see? Have anybody putting on the chat if there's any question? Oh yeah. I didn't realize that there were so many requirements in terms of, for example, the vaccination and so on as the pre-arrival requirement to the program. Is that kind of standard for anybody who wants to go to Vienna as well, or is this just for the program?
I think this is standard because it's in the website. It's mentioned in the website. Yeah.
For visitors to go to Vienna?
Yes, for those who want to do observership.
Oh, observation. Okay.
Yeah,
I thought,
specifically for observership.
not for tourists.
No.
Okay. Yeah, I did because I was in Vienna also last year, I think.
No, you don't have to
So,
do that.
no, I was a tourist. Yeah, that's the advantage then. Okay. Yeah, I can understand because it will involve you know, in a secure location and patient safety and so on. So yeah, that's relevant thing. Okay. Anything else that might be explained further? Maybe our colleagues in Vienna currently, you have any questions, any inquiry about you know anything for Dr. Huda and myself, or anything about Malaysia that you want to know or you're interested in? But certainly our setup is different. Yeah, and our weather is different as well. Getting hot here. Yeah.
the weather. But their summer is more or less the same like our weather.
I think there was a very hot summer, like a hot weather. I think when you were there, but
36.
some places
On
in
the-
South Germany
yeah.
went up to 40 degrees Celsius.
On my first week there, it was really hot. It was 36 with a very hot wind as well. But fortunately, on my second week, it was raining and the weather has become cool, like 18,
Yeah, yeah.
20 is very nice.
Okay. Anyway, thank you for the coffee.
Oh,
Yeah, yeah. It's a Wiener Melange. It's a blend from Vienna. So,
most
but it's
welcome.
from Chibo.
Oh, really?
It's not a, yeah. Chibo is also in Hamburg, in Germany. Yeah. Okay.
Okay.
So we'll
All
try
right.
the coffee. Thank you.
Okay, thank you very much, everyone. It's a pleasure to have all of you to listen to my sharing and hope to see all of you again. For those in Vienna, thank you so much. Bye-bye. Bis später.
Ja, danke schön. Bis dann.
Dankeschön.
Baba.
Tschüss. Ja, ja.
Baba.
Tschüss.